Hello, everyone, and welcome to another session in CME Palooza Spring. I am Scott Kober. I'm one of the CME Palooza co-producers, and I am happy to be joined today by Kurt Boyce and by Amanda Glazer to present their session entitled Achieving Level 7 Outcomes, a MEC Perspective. So a few housekeeping items before I turn this over to them. First of all, we couldn't do this without our sponsors, so I wanted to recognize each of them. Our gold sponsors, Intelligent Medical Decisions and Archimedics. Our silver sponsors, Genentech, iMedix, and MedPage Today. And our bronze sponsors, Advanced Studies in Medicine, Clinical Care Options, CME Matters, CMEology, CME Outfitters, Decision Simulation, I botched that for the second time, Educational Measures, Forefront Collaborative, Global Academy for Medical Education, Highmark CE, Impact Education, Infograph Ed, Platform Q Health Education, and Vindico Medical Education. So during this session, there are three ways that people can ask questions. You can use the MedPage Today text line to send in a question. The number's here on your screen, 267-666-0CME. If you're watching this in the Google Hangout on-air window, you can use the Q&A link located at the bottom of each video. And you can also tweet your question to us using the CME Palooza hashtag. And hopefully folks will have a lot of questions and comments throughout this and every session that we have during CME Palooza Spring. Here's a disclosure slide, so please be aware that the opinions of our presenters are their own and do not represent an endorsement or position of their employer or parent company. So with that, I'd like to introduce our panel. We have Kurt Boyce. Kurt is the Director of CME and Compliance for Applied Clinical Education, as well as Amanda Glazer. And Amanda is the Senior Director of Education Strategy for Global Education Group. And so with that, I'm going to turn this over to Kurt to get us started.
Okay. Well, thanks a lot, Scott. Our topic today is Level 7 Outcomes, a MEC perspective. And a little bit of background on why we're here today or how we got here is we've been hearing a lot about Level 7 outcomes since the early 2000s, and I think there have always been a number of questions about Level 7 outcomes. What exactly does it mean? How do we get into it? And I think that one of the things that we heard quite often early on when we first started talking about Level 7 outcomes, and perhaps even still today, is that they can really only be achieved or measured when dealing with a point of care setting, a hospital or some other kind of clinical setting, and also that perhaps they are something that's fairly onerous. They take a great deal of measurement, a great deal of follow-up, and so what we traditionally think of as continuing medical education and continuing medical education activities really are not appropriate and don't have a place in Level 7 outcomes. And then one that that we're going to try to rebut today, certainly, and that we feel we have, is that a MEC, a medical education company, is not really the provider type who can reach these higher levels of outcomes. That it really takes a group from, let's say, an academic or a professional society setting to accurately do that. And so we call that the challenge, not something necessarily that was thrown to us directly, but that we, Amanda's group and mine, that we did not necessarily agree with, and so we considered this an opportunity. And Scott, if you could move to the next slide, thanks. Why we don't necessarily agree with that? We gave a lot of thought as to why are level 7 outcomes so difficult to get, and why does it have to be something that that is onerous, or something that that defies tradition? We, as MECs, we have a tradition of innovation. I think that we bring that's probably one of the main things that we bring to the CME enterprise is our history of innovation and our ability to adapt. So we wanted to take what we see as MEC strengths, which are things such as efficiency, excellent design and measurement methodologies, and use that to reach those higher levels of outcomes. At the same time, we were working on developing a design for an opioid REMS training initiative, an educational initiative, and we thought that we could blend the two of these together because pain is a very difficult to define disease state or disorder. It's not the same for everyone. And so we felt that by going into the pain space, we could refine what the definition of pain is by using ICD-9 codes. And Scott, if you could move on to the next one, please. So we got together, Global Education Group, which is Amanda's company, an accredited MEC. My company, Applied Clinical Education, which is a non-accredited MEC, and a third party called MedMatrix, which is a group that that works with large Fortune 500 companies and city and state governments and the like to help them monitor the health of their employees. And so the three of us got together and we put together our design for how we can achieve higher level of outcomes, and this included a lot of discussion. We originally got together in 2010 and worked on the design for over a year before we were able to go out and try to solicit funding for it. And some of the key facets of the design that that we struggled with, but that we felt we needed to have, were first of all, we didn't think that you would be able to reach level 7 outcomes solely while dealing from a professional education standpoint. So we knew we needed to include both a professional arm of education as well as a patient arm of education. Secondly, we knew we had to define communities. If we're measuring community health, we need a definition for community. Now, I don't think that that in Moore's outcomes there is an absolute definition of what a community is. I think by necessity, community is something that is rather fluid, because a community may be part of several different communities. What we did is we defined community as a group of employees working for a particular company. And we then measured their baseline pain health, so to speak, by taking a de-identified data pull along the lines of 20 ICD-9 codes. We worked with the health department, the medical departments within these companies, and were able to pull data along these ICD-9 codes, and we were able to get a sense of how often people presented with claims along those lines, and what the cost of those claims were. And so we then knew we needed to put in a post-intervention data and do a post-data pull. So that was the basic design element in large scale that we had for our initiative, which was called Remedies. Now, how we delivered it is, as I mentioned, we had two different arms. We had the professional intervention arm, a patient intervention arm, and then we sort of had something that was a joint intervention, though not certified. I'll tell you a little bit about them right now. First, within the professional intervention, we had a core curriculum. This was something that was meant to address the 6 sections of the FDA blueprint on extended release and long-acting opioids. This consisted of both a series of live symposia and a videotaped monograph or webcast of that live symposia, or one of those live symposia, which were then placed online. And then we developed a supplementary curriculum that would address areas of greater difficulty among learners on the core curriculum. On the patient side, we developed a series of seminars and screenings at the location of each of the 3 employer groups with whom we were working. And the location of the employers, in order to get a very clear sense of community and trying to link the education for patients with the education for the professional audience, we held the live symposia in the same locations where our employers were located, so that we were dealing with the same groups of physicians that employees would be likely to visit for treatment for their pain. So that's how those two intersected, and we gave the patients screenings along the lines of interviews and use of pain scales and so on. And then we went out and delivered the education within the same geographic regions, as well as on a national basis. And then we did follow-ups 6 to 8 months later on the same utilization and cost data that we had pulled in the initial employer insurance records. And that's what Amanda is going to tell you a little bit about right now.
Thanks, Kurt. So as Kurt mentioned, listed below are the 3 different employer groups that we held our patient screenings and our patient seminars. And as I mentioned, they coincided with the 3 live seminars that we did for physicians in the same geographical areas. So the New England Tractor Trailer Training School was in Boston, Massachusetts. We had 154 attendees attend the patient seminars. The Peninsula Electric Distributors out of Miami, Florida, with 67 attendees, and the Canal Cartage Company out of Houston, Texas, with 74 attendees. One item of note for the results is that employees from Boston did report the most symptoms of pain compared to the other 2 locations, and this is based on those patient screenings and those pain scales that we used.
Now, Amanda, how did you pick those 3 locations or those 3 employers?
So, working with MedMatrix and their experience with different employer groups throughout the areas, we knew that we were going to be providing physician-level education in those geographical areas, and so we worked with them to identify companies that had that we hypothesized had employees where there would be a large amount of pain, and also coincided with the areas of where the physician education took place.
Okay, thanks.
This is just a screenshot of the opening slide for the pain seminar. So educating them on acute and chronic pain. The educational presentation really focused on a lot of the signs, the symptoms, what questions they should be asking their doctors, and some of the new treatment options that are available for them so that they could bring all of that to their physicians. As Kurt mentioned, we looked at 20 different ICD-9 codes related to pain, and when we took the top 5 codes that were reported for pain, they were the same for all 3 cities. So lumbago, sciatica, thoracic or lumbosacral neuritis, backache unspecified, and osteoporosis. So those were the top 5 codes that were recorded for the physicians of the employees in those geographic regions, and so that's what we looked at. And then to get to kind of the bread and butter of the results of this part of our education, we can see that there was a 12.8 average increase in employees seeking medical care for one of the 20 pain-related medical issues. As I mentioned, I shared with you the top 5. And so while we did get an increase in employee claims, we show that that correlated with a decrease of 8.3 average decrease in payments across all of those ICD-9 codes. And that showed a collective savings of about $58,000 among patients in their healthcare costs. So the relationship between the education that we delivered caused them to go to their doctors. Maybe they went sooner, they were able to get the correct diagnosis more quickly, so there was less follow-up visits, or they were able to be started on treatments that were more correct for their diagnosis to begin with, therefore resulting in less costs across all of those ICD-9 codes. So really great data, really great information related to those specific employees within that community that we defined. We don't have a slide for this, but I also wanted to just kind of run down a couple other quick outcomes points and highlights from their remedies initiative as a whole. We reached over 25,000 physician, nurse practitioner, physician assistant participants, and over 4,300 CME certificates were generated. We saw an increase of about 39% in knowledge and 43% in competence. And this is over all of the different interventions that we utilized for remedies. As far as performance, we saw a performance increase of about 67% among learners. One of the other interventions that that we included in remedies was a PI initiative to reach level 5 and level 6 data. One of the exciting things that we got from the outcomes of the PI is that physician behavior increased by 96% between stages A and C, and that over 300 patients were documented and measured, and therefore hopefully benefited from the information that the learners took away from that PI initiative. And I just shared with you the results of the level 7 with our employee screenings for the pain codes. So overall, a great initiative that we thought was a really valuable therapeutic area, especially with REMS coming out, and especially in the areas of Florida, Texas, and even up in Boston, areas of high incidences of pain, to be able to educate not only the physicians but the patients in those areas as well.
I would also add that what Amanda was talking about in terms of a performance improvement activity and the measurement for levels 3 and 4 and 5. 2 other groups that were partners with us in the overall initiative, not necessarily specifically in the level 7 outcomes, were Intelligent Medical Decisions and Real CME, who really gave us some great data for level 6 and level 5 respectively.
Okay, so a couple of questions I have for you guys. So first of all, if you were to do this again, what would you do differently? So next time that you would develop a community health initiative, what might you do differently?
Well, I think one thing that I would try to do differently is make a clearer connection between the health plans itself and the physicians that we are educating. What we've got now are data that came from the same community where the professionals were practicing and the employees lived. I think that I would probably try to do something, if we could, that tied in specific physicians with de-identified patients, the employees as a whole. That's something that's a little bit trickier, though, because you need a lot more buy-in from both sides of the fence there. But that's something that I think would deliver even more interesting results.
Amanda, do you have any thoughts?
No, but I agree with Kurt. I think the struggle that we face in the CME community in general is getting that buy-in, as Kurt mentioned, from the physicians and being able to link them directly with their specific patients.
Okay. So the other question I have, this refers to something that you said earlier, Kurt, about how it's really incumbent or the provider can define what is a quote-unquote community when they're measuring community health, and that it doesn't have to be you're measuring every single person living in the state of Massachusetts. You can kind of have a very small defined community. So at what point is a community too small? I mean, you can't just say we're going to improve community health by focusing on the members of the Boyce family.
Mm-hmm. I guess that's really up to the designers and what their setting is and what it is that did remedies program and what we hope to do again is we are assuming that anything that really goes beyond what you might expect in a performance improvement activity. Amanda alluded to what Intelligent Medical Decisions did in terms of gathering data on a practice-by-practice basis. And I guess in terms of community, you know, if you can even get groups of 25 or 50, maybe a small community, but it is a group of patients with a common disorder or a common complaint, and you can measure how they are affected by a particular intervention. In our case, we were dealing with something around 300 patients total. So we define community as being an employee of one of the three organizations with whom we partnered. Now you could also take that in the other direction and expand it so that these people are not only part of that community, but they are part of a larger state or regional community, which is something that we hope to do in the future by measuring community versus community in some of the future initiatives that we're designing.
Okay, great.
I don't know, does that help answer your question?
Yeah, I think that's great. Amanda, do you have anything that
No, I think Kurt, you hit the mark right on the head. I think one of the biggest things about community that we were unable to measure, but hoped that is something that we could design in the future is, while we only educated a small portion of the employees within that group, our hope is that those particular employees that attended those seminars took that education and spread it to the rest of the employees within their organization as well. And so hopefully there was a trickle-down effect of spreading that education out and help educate the bigger part of the community.
Okay. Okay, great. So to wrap it up, Kurt, maybe you guys want to briefly talk about what's next for this initiative?
Well, this initiative itself completed its period of certification in December of 2014. So Amanda and I are working on developing a manuscript where we hope to publish the results of the initiative, and hopefully that's something that we'll be able to have out in publication by the end of the year or early in 2016. In the meantime, we are working on designing some other similar initiatives, not necessarily within the same space, but other initiatives that entail similar designs.
Okay. All right, great. Well, thanks, guys. I know that this was one of our half-hour sessions, so we're right up coming to the close. So before we end, just want to give people a reminder for those who are watching CME Palooza Spring. There is a brief survey at the top of the live tab. So if you could please go in to complete that, whether you're watching this live, whether you're watching the enduring version, it'll give us a better sense of who's watching this and sort of give you a chance to provide some feedback on the event. And our next session will be starting here in a little less than 5 minutes. So you will need to refresh your browser once we end this session to view our next session. And with that, I would like to thank Kurt and thank Amanda. And hopefully you guys have provided some food for thought for people who are going to be designing these sorts of educational initiatives in the future.
Okay, thank you, Scott.
All right, bye-bye.
Okay.